Good afternoon, my friends and colleagues. Millions of people affected with COVID-19 worldwide, and many died linked to COVID-19 related illness. Importantly, and relevant to our practice, this novel coronavirus strain appeared to cause most severe infection with potentially fatal outcome in older patients and patients with underlying comorbidities, including immunosuppression host. This is highly relevant topic in current era. I'm not going to discuss already published multiple guidelines, which is easily accessible online, free open access, and it's high likely that global or country-specific guidelines may not be relevant to your practice, and particularly your center. So my goal in next 40 minutes or so is to share our experience, how we have changed some of our practice, especially supportive care practice, and share with you all some of our recent articles. I have no conflict of interest to disclose. So let me start with our recent editorials. Editorials reviews and cites recent publications and outline the potential challenges and solutions to mitigate the impact of COVID-19 in our patient. As a hematologist, oncologist, we are both hematologists and oncologists, we are used to seeing lots of critical illness in patients with advanced and refractory malignancies. Management of hematology patients may pose severe special challenges during COVID-19 outbreak. While it's important, and for consistency, we apply homogeneous guidelines for patients' management, but it appears that some decision needs to be taken on an individual basis at the institutional level, and this is very important. It all depends on where you are living, what is your support system. Many factors need to take into consideration before we make a decision. At the same time, a missed opportunity for patient to receive the most efficacious treatment, as for example, transplant, on a timely basis may result in relapse or progression of their disease. They succumb to disease before they can catch COVID. The ongoing lessons from COVID-19 outbreak suggest that time has come. Time has come for all of us to think differently in a way we deliver and disseminate our experience. Talking about our experience, let me start with our COVID-19 experience over last 9 months. And it's still ongoing challenge. We are not done yet. I think multiple publications, including our society guideline, ASTCT, ABMT, NMDP, WMDP, FACT, JESI, many other organizations have published a lot on COVID era management. Credit goes to this organization developing some document how to keep our patients safe and consider when to consider transplant cellular therapy in need of patient during this era. At the same time, institutional guidelines, very important on approaching leukemia and transplant patient, very important and helpful because at the institutional level, we need to work differently with additional multiple challenges. So we are high volume transplant program. For FACT application, we are 2-site 1 program, Vanderbilt University Medical Center program, which includes adults led by medical director is Dr. Kasim, and pediatric program, Dr. Kerry Kitko is our medical director. For Veterans Affairs Medical Center site, Dr. Stacy Goodman is our medical director. In combined, we perform around more than 350 transplant average, 30 transplant a month during pre-COVID era. We are a high volume program and +1 program. Slide shows our transplant outcome, combined both auto and allo from March to October 2020 COVID-19 era. Looks like volume keeps rising in month of September, October, and also in November because I was on service last 4 weeks, 2 weeks at Vanderbilt and 2 weeks at the VA transplant program. Just came off service yesterday morning. November data not reported yet, but experience by self busy volume when I was on service. Initially in the month of April, we deferred quite a few transplantation because patient with low risk malignancy or non-malignant disease based on our recommendation from the institution. We differ many non-malignant disease, especially sickle cell disease. We are good sized sickle cell transplant program. Credit goes to our medical director, Dr. Kassim. Then in early May, we realized the need, explosion of waiting list. And at the same time, we have had a great system in place to manage the increased volume. We are now almost back to pre-COVID era volume. Slight drop in volume in August, you can see here, probably related to second COVID-19 wave. We are predominantly outpatient transplant program, as you know. That helps us a lot to keep up with our transplant volume. And it helps us to preserve inpatient bed for COVID-19 use if needed. In our program, almost all patients start transplant or CAR T therapy in outpatient transplant unit. I mean in commercial CAR T, Kymriah, Yescarta, Tecartus. Patient on CAR T clinical trial do require initial hospitalization. Everything start outpatient except patient receiving unrelated donor or patient receiving thymoglobuline, they do get admitted for those period of time. And those receiving haplotransplantation, they get admitted for 5 days for stem cell infusion and post-stem cell infusion monitoring for CRS and post-transplant cyclophosphamide. Otherwise, everything done as an outpatient. Like most program in the country, increased utilization of related donors, especially haplo. Haplo account for more than 60% of allotransplant nowadays. I don't have exact number, but most allo recipients receive haplo product nowadays. Use of unrelated donor in this period has declined significantly. Like most programs, we always secure donor product first. We freeze both allo and auto product. From our limited experience, similar to published data in leukemia and heme malignancy, recently CIBMTR study on leukemia and heme malignancy, we didn't see the compromised outcome similar to published data. We'll review our outcome data in next few slides. We also did not observe any increased rate of early graft failure, nor any impact on time to neutrophil or platelet engraftment in COVID-19 period using project product, including few patients with severe aplastic anemia. Any impact on transplant outcome? Answer is no. Among allotransplant patients, 100-day overall survival was similar in COVID-19 era compared to pre-COVID-19. 95% for 100-day survival for COVID-19 cohort during this time from March to October, and 94% for the same time period pre-COVID era. Similarly, no difference in outcome for auto transplantation, nearly 100% day 100 survival among auto group both in pre and post-COVID era, during COVID era. So in terms of infection, no patient transplanted the period were diagnosed with COVID-19 infection in their first 100 days after transplant. There were few long-term allotransplant patient survivors, real long-term survivors, acquired COVID-19, but not aware of any mortality in allotransplant patient. I worked on long-term transplant clinic on both sides, and I don't know any mortality in allotransplantation patient who died from COVID-19. However, 2 auto patients far from transplantation died related to COVID-19. I would not link them related to transplantation because one patient was mantle cell lymphoma, CR1, doing very well, 8 months post-transplantation, acquired COVID, and he died. And there was one more patient, amyloid patient. I'm not sure patient died or not our site, outside, but transplanted at Vanderbilt in our amyloid VAM program. But he was sick, and I'm sure he died. I need to re-verify it. The rate of non-COVID-19 infection appears similar. However, no formal analysis has been performed yet. I can say strongly that our patients are very sad. They tried their best to protect themselves. In addition, there was no grade 3 or 4 bleeding episode reported among our leukemia and transplant patients during this time period, despite highly restrictive but approved transfusion practices, which we will discuss in the later part of the presentation. So let me review some recent publication and information so we continue to improve our outcome during and post-COVID era. Key goals are summarized here. To protect the highly immunosuppressed patient, we all agree with that. To maintain high standard of care during pandemic. And then protecting healthcare professional. Protecting healthcare professional is equally very, very important. We can't expose our all staff to the risk of COVID-19 at the same time, because if 10% of your staff are quarantined, you might need to cut down the patient volume to provide quality care. Backup coverage, very important. And protecting frontline staff like residents, fellows, nurses, nurse practitioners are very important, and we have practice in place. Let me give you our best practical example. For attendings, we do have first backup and second backup. So person who is on service attending, he will be seeing all in-person patient, inpatient, and outpatient daily. Second backup person will share the duty as an inpatient clinic visit, not early post-transplant, but routine clinic visit, and he will also do some telehealth. While second backup person will continue to do most telehealth visit. At the same time, for other clinician like nurse practitioner, they rotate as an in-person clinician for direct patient care and virtual for telehealth survey. So not all staff get exposed to COVID-19 risk at the same time. And clinical staff who is on the telehealth or backup service ready to take over the busy service anytime without interruption in service. So frequent, this is also very important, frequent COVID touch point meeting. That means we meet at least 2-3 times a day, 2-3 times a week. Our right now schedule is Tuesday and Friday. We call it COVID touch point meeting, discussion, very important. Sometimes it feels like boring. Same discussion all over again every time we meet in each meeting, but very useful keeping up the volume, transplant volume, and for patient safety. What we discuss in our program, summarize here in next, and also in the next slide. Should we postpone transplant or CAR T therapy during pandemic period? This is what we discuss in weekly discussion for upcoming patient. Any dropout due to a variety of reasons, we need to have patient ready to move up to keep up the volume and also to benefit our patients. If we decide to delay transplantation, what are the alternative options? Our leukemia team members help us with non-transplant management option. And information is generally related to referring physician if they're not part of the not taking treatment advantage of it. What should be the attitude towards stem cell mobilization and collection? As we discussed before, we always freeze auto product. So not much change in policy, but we do not defer any auto transplant nowadays, unless any active infection or disease progression issue, which is a common indication to drop out even in non-COVID era timing also. So important discussion for transplant patient with GVHD, very important, patient getting GVHD. How to handle high dose steroid dose. To me, outside the clinical trial, I don't see any indication to give high dose steroid. Lately, I have very rarely used even prednisone 0.5 milligram per kilogram equivalent dosing. GVHD practice is changing rapidly. In our program, I'm known for 20 milligram prednisone. Main reason we don't see much severe GVHD, that's another reason nowadays. And second reason is early strike always help. Are there any prophylactic measures to prevent COVID-19 infection? Just all aggressive precaution, educating staff and our staff, clinical staff, to get education in person by the group team members and also by online testing. Caregivers education is also very important. If caregivers get infection, who will take care of patient? We have to have a first backup, second backup, caregiver also. And we have had a situation where patient had caregiver positive for COVID-19, and we needed to find out how do we handle. Only option is inpatient. So caregiver education is very important. How to handle the specific hematological therapies in patients suffering COVID-19 infection. Now, let me tell you, and I mentioned before, we have not seen much interruption except in month of April. Look like we are almost fully operational at present. Next is how to handle clinical research protocol during pandemic. The short answer, this is very important because most resources are utilized for standard of care management and expected shortage in research staffing because many of these staffs are pulled for clinical duties. Our research team led by Drs. Mike Savona and Dr. Bunn, who looks at transplant research, and they give team, and they have a wonderful team. The team prioritize the highly impactful study, and then we can continue with whatever possible research we can take on. So in this second part, this is one of our recent publication in Surgeon, sort of combine consensus and new and review article published in June this year. Open access article, easily accessible, and some useful information. Summary of article reviewed here. Many of these recommendations may not be relevant nowadays because most programs have restarted all aggressive management policy and they have all increased volume to treat leukemia and transplant patients. Our leukemia volume have not declined like most programs, and practice also not changed much, except some supportive management practice changes, particularly transfusion support during COVID-19 era. Transfusion support practice has changed remarkably. We'll review soon in next few slides. This one again, excellent relevant article. Similar recommendation by ASTCT also published recently, available on ASTCT website, free open access. Now, the limitation of all published articles by ASTCT, ABMT, PSTCT, British Society, APBMT are, I would say these are generalized guidelines. It may not be institutional or region specific, and that's a major limitation, I would say. You need to modify it. You need to modify and revise the recommendation to be implemented at your institutional level. There is always need to be modification. So now next few minutes, I will review this very important supportive care topic in COVID-19 era. Now, detailed presentation on supportive care during COVID-19 era was reviewed last month in our virtual ISCH meeting, first week of October. I think detailed complete presentation of that meeting is available on ISCH website. Most of our leukemia patients on induction or consolidation chemotherapy and almost all transplant recipients do require PEC-RBC, transfusion, and they do require frequently. If we can't provide transfusion support, we can't treat leukemia and transplant patients, right? We rely on millions of volunteer donors who donate their blood products. And this is how we survive and we cure patients. So why this is very important? What is the problem with COVID-19 pandemic and transplant practice in leukemia and transplant patient? Transfusion practice in leukemia and transplant patient. Major issue. Blood supplies faces ever increasing challenges. Blood donation deep in warm month with increased travel referrals. Younger donors are less frequently available, enjoying summer vacation time and now Thanksgiving time. Lots of travel despite CDC and health professionals warning. I'm sure you heard millions of people are traveling this week for Thanksgiving celebration. But these issues are made especially challenging in the COVID-19 pandemic. Several factors have contributed to worsening stocks of blood supply in COVID-19 era. Around main June 2020, early this year, our leukemia and transplant position back to pre-COVID era volume because we increased, as you know, we explained before. At the same time, most hospitals started reopening for the elective surgery. Many patients were awaiting planned surgeries back on schedule. At the same time, cancellation of blood drive, a reduced capacity for blood cancer blood collection center resulting from implementing social distancing and safety guidelines. And patient, donors, volunteers, they also scared to go to those mass gatherings. Despite it's not mine, because most of the blood donation camps, they do follow social distancing and do practice mandatory mask. This disrupted the overall inventory of blood for our leukemia and transplant patients. What can we do? Clinical team members should remain vigilant in their blood use and continue to transfuse only when necessary. Evidence-based guidelines for transfusion practice in leukemia or stem cell transplant population includes recommendation from the AABB, American Association of Blood Banking, to restrict red transfusion practice with hemoglobin threshold of 7 grams or hematocrit of less than 21 in majority patients. I was on service last 4 weeks, just came up on yesterday morning. Less than 21, that's my main goal to transfuse. And some younger practice, less than 80 only, as long as they are asymptomatic. And there was no adverse event reported in last 4 weeks. And that's what the policy most centered, less than 21, even in elderly patient, but fit, no cardiac history. Randomized controlled trials in oncology patients comparing liberal versus restricted transfusion strategy have identified that lower hemoglobin thresholds are no worse than liberal transfusion triggers of high. Recommendation for restrictive red cell transfusion strategy in the absence of symptomatic anemia or hemorrhage are advised. And this is what we follow, and no adverse events so far. Now let me review platelet transfusion practice briefly. Prophylactic platelet transfusion platelets should occur at threshold of 10,000 generally for all hospitalized patients. This is common practice, right? Now the top trial demonstrated, and reference here, reduced bleeding with prophylactic transfusion in patients below this level. And similar trial compared prophylactic transfusion at 10,000 or less versus platelet transfusion for symptomatic bleeding, irrespective of platelet count. If platelet count is 1, no transfusion unless bleeding among acute leukemia patient and auto transplant patient. Data showed no increase in severe bleeding, grade 3 or higher, with only prophylactic transfusion, meaning if you waited for bleeding before platelet transfusion, not a problem. There was no severe bleeding in this group compared to who received prophylactic transfusion. But we don't practice most of the time. Let me review both for hematocrit and platelet, because this is very important in COVID-19 era. We need to change, and this is how we can help other patients and conserve the resources. Let me review some of transfusion misconception. It needs to be resolved to save product for needed patient and to avoid shortage during this time. Classical scenario and round. Resident, fellow, or your nurse practitioner will say, although hemoglobin is 8.9 today, but patient is weak. Requested or transfusion pack RBC, wrong practice. Another common scenario, hemoglobin is 7.9. Let's bump up hemoglobin, give 2 units of pack RBC so we don't have to transfuse for next few days. Remember, you give only 1 pack RBC at a time unless any emergency. And I don't think this patient needs transfusion unless symptomatic and strong cardiac history. Rate is more than 21. Classical other scenario in patient with cardiac history, which has always been there. Patient with history of CABT 10 years ago. Hemoglobin 8.3 today. After consolidation chemotherapy, received back RBC to keep hematocrit more than 9. Now, despite this receipt, despite cardiac evolution was totally normal before chemotherapy, transfusion not needed in asymptomatic patient and cardiac condition is fixed several years ago. Maybe his patient's heart is better than my heart. Elderly patient, another scenario with AML, is on day 26 consolidation chemotherapy, asymptomatic. Hemoglobin 8.1, and nurse practitioner want to give back RBC, so we can give 3 days off. Wrong practice, no transfusion needed. 79-year-old relapsed refractory AML decided to stop therapy, terminal case, life expectancy few days, plan to go home on hospice. But team decided to continue to give back RBC so she can feel better. Generally, you don't give transfusion once patient is on hospice care with survival in next few days. It's troubling and unnecessary. These are very common misconceptions to justify red blood cell transfusion without any scientific basis. Wrong transfusion practice, and very important during this COVID-19 era. Slide summarizes some common misconception in reference to platelet transfusion. In patient with leukemia or transplant after chemotherapy, patient has a fever for past 4 days. Let's give prophylactic platelet transfusion threshold to higher, more than 20 instead of 10. Wrong practice. No scientific basis unless patient has active bleeding, right? But people still practice this all way. Another scenario. Patient has lost of bruising after chemotherapy. Let's change platelet threshold to higher. Again, wrong practice in most cases. Sometimes you will get call from residents, fellows, NNP. These are the ones requesting transfusion. Many a time, by the time you are in the round, transfusion is already done. So you need to educate them. So frequent call from resident fellows, NP, that we have lots of transfusion in blood bank. Got call from transfusion medicine department, and patient platelets are expiring today. Can we give transfusion to our patient? We don't need to give it tomorrow. Again, wrong practice. Ship, if you have extra platelets, ship to needed facility or center where probably they need more than us, if you don't need today. Patient has another example. Patient has no active bleeding, but no response to platelet transfusion. But continue platelet transfusion twice a day. Refractory platelet. And we do see in our practice leukemia, transplant, 5 platelet before transplant, a transfusion, and 5 after. There's no need to give twice a day. Generally, no benefit unless active bleeding, and then you need to do something else. May be harmful by giving repeated transfusion without response than benefit. Another scenario. Did you check platelet count after prophylactic transfusion? Not needed unless circumstances is like patient with low platelet on anticoagulation. And you're trying to keep platelet at certain level on anticoagulation for thromboembolic complication. Risk of thromboembolism is very high in our patient. Many of our patients are just relaxing more than ever before because COVID-19. They're scared to go out during this time. They always think COVID-19 is out there to waiting for them. And that's good. They're keeping social distancing and lockdown. But that relaxing time can further increase the risk of thromboembolic complication. This is one more common misconception issue. Low platelets can't give anticoagulation for blood clot or for history of atrial fibrillation or valvular heart disease, which needing anticoagulation. Strong misconception. Yes, you can give anticoagulation unless patient is actively bleeding. Keep platelet higher by transfusion. Try to keep platelet count above certain level depending on your goal, type of underlying condition. Details summarized in this publication summarize here. And I'm sure you all are aware the journal Chest publishes consensus anticoagulation guideline for most conditions needing anticoagulation. I call it a Bible of anticoagulation guideline. I think they publish every 4 years. So we reviewed the transfusion misconception. Let's review the truth about transfusion now. Transfusions are inherently hazardous. We need to learn now, especially this is the best time in COVID-19 to change our practice. While transfusion products are safest in the history, transfusions are not free and can cause a degree of harm, like rare infection risks, patients' misidentification, transfusion-related acute lung injury like TRALI, or transfusion-associated circulatory overload, which is common in our practice. Less is more for transfusion. Best available evidence for transfusion therapy indicates that a more conservative approach to blood transfusion not only save blood product, but also improve outcome and save lives. You need to cut down the threshold to less than 21 and sometimes less than 19, less than 18 for a young healthy patient, asymptomatic patient. Transfusion education is a mess. This is a reality. As I told you before, most transfusion products are ordered by residents, fellows, nurse practitioners, nurses, some places. Most clinicians who order blood products, I'm not saying they're not educated, but sometimes, most clinicians who are ordering blood products lack formal training in transfusion therapy and are unaware of current transfusion guidelines. And this is a truth. We need to accept it. We need to educate them. Blood shortage and blood cost have hospitals saying red. Blood prices have doubled in the past decade, and prices are expected to increase by 6% to 10% per year going forward. Blood costs are tip of the iceberg for total cost of transfusion. Total cost of transfusing patient exceed blood acquisition costs. It's just tip of iceberg. It's by 5 times higher, greater than 5 times. When we include labor, supplies, blood administration, and rarely transfusion-related adverse event costs, which is tremendous. Transfusions are risky business. Liability of inappropriate transfusion reactions, errors can be substantial. Transfusion complication, you break it, you pay for it. Financial penalties for adverse clinical outcome related to inappropriate practices are increasing. I'm sure you know that Medicare and most commercial health insurance carriers will no longer pay for transfusion errors, bleeding complication in cardiac surgery, and a growing number of hospital-acquired infections that are increased by blood transfusion. We do have stringent prophylactic transfusion support criteria. We have changed our practice recently. Slide shows the list of our SOPs, including blood and blood product SOP. Just to give an example, patient undergoing auto transplantation and admitted to the hospital do not need prophylactic platelet transfusion unless there is a clinical bleeding and very restrictive transfusion practice for our leukemia patient on consolidation therapy. So if patient is inpatient, let's say patient is on beam auto transplantation for any lymphoma, platelet count is 2,000, but no active bleeding, and if he or she is inpatient, no transfusion, irrespective of platelet transfusion. I forgot to mention in the previous slide this one. This is a relevant article just for educational purpose. This article was written with my friend, transfusion medicine colleague and friend, Dr. Garrett Booth for ASTCT Nucleus. It's very relevant to our COVID-19 practice for leukemia and transplantation. Nucleus is a new way for society to share information to the membership. This online magazine is a hub that features articles ranging from human interest pieces to recipe for what's happening on the Capitol politics. So this is my now last slide, summary slide. With this limited review of leukemia transplantation in COVID-19 era, we can say COVID-19 pandemic introduced many challenges for our patients and providers. You can agree that changes made during this pandemic era enables us and patients to safely receive potentially life-saving management. It is important to conserve resources, including safety of frontline staff, care for backup plan on a regular basis. It's a continued process. No benefit of prophylactic transfusion in most patients. We always transfuse more than needed, way more than needed. Follow the recent published guideline. AABB has a wonderful article. Important lesson learned during pandemic: minimizing transfusion support, not compromising overall outcome in leukemia and transplant patients. Perhaps it's beneficial. Bottom line, we, meaning all clinicians across the globe, are doing superb job. We have never compromised outcome despite lots of ongoing struggles and challenging issues. I thank you very much for your attention, and I'll be happy to answer if you have any questions. Let's look at the chat box. Please send your question to this chat box in case you may have anything. Feel free to send the question. This is my email ID in case you don't want to send a question via chat box, and I'll be happy to share my presentation. I'll be happy to share the articles which we publish and some of the open access articles. I think thank you very much for your time. Arnold, I think we are done.